Reproductive Medicine in Columbus, Ohio. I'm hoping that you guys will have a great experience with the event today. Again, just in case I started speaking before we went live, my name is Dr. Brooke Rossi. I am a reproductive endocrinologist and infertility specialist at Ohio Reproductive Medicine, which is a practice in Columbus, Ohio. And, often we get patients from our practice that join the talk, but sometimes there's patients from different parts of the country and the world. So it's nice to meet all of you. There were some, if you had RSVP to the event, there are some different questions that people have asked. What I'd like to do before we jump into all the questions is just to give people a little bit of an overview about how a patient may end up seeing an infertility specialist. So one of the main reasons why people might see an infertility specialist is because they're having trouble getting pregnant. The definition of infertility, so it actually can be defined in a couple ways, and I think this is worthwhile to mention. So one of the more, I think, easy and understandable and well-accepted definitions of infertility is that somebody has tried to get pregnant for at least a year or has kind of exposed themselves to getting pregnant for about a year. So I think there's a difference too, right? Because sometimes people will say, well, I stopped birth control pills 3 years ago when we weren't preventing anything. That's still kind of exposure to being able to get pregnant versus, we were trying really, really hard every month for 12 months. So I think it's important to understand, like, if you've really, could have gotten pregnant and it's been, at least 12 months, that may be a reason to check in with your doctor. Now, the criteria is different in other situations. So if somebody is 35 years or older, that might be a reason for them to seek an evaluation sooner. But then there's other situations. If somebody, has endometriosis, if someone's been told in the past that they had a medical issue that may make it harder for them to get pregnant, if their male partner has been told it might be harder for them to get pregnant, if they're not having regular periods, those are reasons that people don't have to wait to see either their doctor or a specialist. And then, of course, there's a whole group of people who maybe can't get pregnant, either because they're in a same-sex relationship or their partners, don't have sperm, don't have eggs, or maybe they're a single person. Those are all situations. I mean, you may seek the help of an infertility specialist soon. And the other thing, I just want to touch on is I do sometimes see patients who may be frustrated because they're asking for help and maybe their doctor doesn't think they need help. And so maybe they're not responding to them or they're not hearing their concerns. And this even happens with young patients. I do think that the stereotype is that maybe infertility patients are always, in their late 30s, but I have a lot of young patients who have been trying for over a year. They're trying to get help and they're not being sent to an infertility specialist. And most of the time, you don't need to have permission from your doctor or a referral from your doctor. A lot of times, even with insurance, you can just find a doctor. You can Google, you can talk to friends or family, and you can find an infertility specialist. And we do sometimes have patients, a lot of times, who just will come and see us because they have concerns and maybe their doctor didn't think they needed to see somebody yet, but they really felt that they needed to see someone. So, there's always infertility specialists available. Even if the conversation is, even if you see the infertility specialist and they say, you've only tried for a certain amount of months, maybe we can do some testing, maybe we'll hold on treatment, but at least you can check in with somebody and make sure that your concerns are being heard, and maybe they will find something that's concerning. So just want to make sure that you understand that, the criteria for when we see and when patients can see infertility specialists. The other thing that an infertility specialist will do is we spend a lot of time talking with patients. So we have, sometimes the initial visits, I feel like I exhaust all the patients because we're talking for so long, but we do a lot of investigation in histories and medical issues, medications, lifestyle, period history, gynecologic history, medical history, sexual history. We ask all these questions of the patient and their partner so we can try to understand if there's any issue. Sometimes with the first visit, you may have an ultrasound done. Often at that first visit, they may make a plan to have you get additional blood work done. The blood work may be hormonal testing. It may look at different hormones from the pituitary gland, like TSH hormone, which has to do with the thyroid, or prolactin hormone. They may think about doing ovarian reserve testing, like an AMH or an FSH. They may talk to you about doing a fallopian tube evaluation to see if your fallopian tubes are open. That's called an HSG. And then if there's a male partner involved, they may consider doing a semen analysis as well. Once that testing is done, often then they'll talk about a treatment plan, and that really just depends on, what the different diagnoses can be. I will take a little break here. And I can talk forever. So let's go to the questions just for a second, so we can see if there are any questions. One of the ones I did get was a question about an HSG. So an HSG stands for hysterosalpingogram, and that is a very long word to say it is an X-ray test that looks at the inside of the uterus, or the uterine cavity, and the fallopian tubes. So essentially what it does is it looks at the shape of the inside of the uterus and the patency, or to see if the fallopian tubes are open. So some of the things that we can identify in HSG are uterine polyps, uterine fibroids, a uterine anomaly like a septum, uterine scarring. Sometimes we can see if the fallopian tubes are open, or we can see if the fallopian tubes are blocked. And the things we can't really tell, though, is we can't really tell how well the fallopian tubes are working. We can just kind of see if they're open or not. So one of the questions that we had from one of the participants was, if the first HSG is inconclusive of blocked tubes, is there a way to confirm or rectify the issue? So there's kind of two different types of blocked tubes on HSG. Sometimes the fallopian tubes look like they're blocked at the beginning, or like the dye didn't even go through the fallopian tubes. That is called proximal blockage. And a lot of times proximal blockage, especially if it's only on one side or like only one fallopian tube, sometimes that is not necessarily diagnostic of a blocked fallopian tube. Sometimes the uterus contracts really tightly during the HSG, and it almost kind of closes the little opening of fallopian tube so the dye doesn't go through the tube. So it's called tubal spasm, and it can happen a significant amount of the time. So sometimes when I see like one open fallopian tube and proximal blockage, I kind of almost think that's almost like a no read. Like, I don't think we can say that tube is blocked, but we also can't say whether it's open or not because we can't see the end of it. If the dye really goes all the way through the tubes and it looks like the tube is blocked at the end, then the tube is usually blocked. And then, the egg can't get into the tube, and that can be an issue with fertility. If the HSG is inconclusive, I mean, for those of you who've had an HSG, it's a pretty miserable test, and it's also pretty expensive. So often we don't love to just have patients go ahead and do it again. So if somebody has one open fallopian tube and proximal blockage, often we'll just say, you know what, you got one open tube, the other one's probably okay, let's just move ahead with whatever treatment. If neither of the tubes has proven patency, that might be a reason to either do another HSG or maybe do a laparoscopy. A laparoscopy is a surgery where the camera goes into the belly button, and we can do a surgery where we put dye through the fallopian tubes so we can see if the fallopian tubes are open. That's obviously a very invasive test, and sometimes we might opt not to do that, but that's another option when people aren't sure if their fallopian tubes are open. And if you had the surgery, you might be able to fix the fallopian tubes at that same time as well. Okay, I have a message. Okay, so this is a question from a participant who says two hopeful moms. So we have a lot of patients in our practice who are moms together. And the question was kind of about if somebody's, in their, in ages, like, how do we manage two women who are trying to have a family? So I think it's always helpful when a couple comes to us, maybe two women who are trying to have a child, to kind of have an idea of, how we're going to go about that. The most simple way, and the way that most people choose, is to do donor insemination, which is to choose a sperm donor and then to have one woman be inseminated with the sperm and then have a child. And then maybe the next time the other woman would get inseminated with the sperm. The second option that some of our patients choose is to do something called reciprocal IVF. And reciprocal IVF is when one woman will go through an IVF cycle. We will collect eggs from her. We will fertilize the eggs with the donor sperm. And then the other woman has the embryo put inside of her. So the woman that's carrying the pregnancy is not genetically related to that baby, but it's a way that both women can take part in the creation of that child. That can be, much more involved and more expensive because it involves IVF. So I think what a lot of patients will do will be to, if both partners want to carry at some point, one goes first and then the other one chooses to do it. And so some of the things to think about would be, what are the age of the patients? Does it make sense that one person has a baby first because maybe they're older? Are there any other medical issues that we're concerned about? Is there a medical contraindication that maybe one person doesn't want or can't carry a pregnancy? And then sometimes there's a person in the couple who maybe just doesn't feel like they want to carry a pregnancy. So maybe that's a good opportunity for them to have eggs taken from them and have their wife or their partner carry that pregnancy. So I think in general, if all other things aside, depending on the ages of the partners, maybe the older one going first, as long as that still allows time for the other one. But there's like many different ways you can do them both at the same time if you want. There's all different ways to do it. And the amount of testing that women who are using donor sperm need can vary. I mean, a lot of those women don't have infertility because maybe they haven't tried ever to conceive. So the amount of testing that goes on kind of can vary, but it may include hormonal testing, ultrasound, fallopian tube test. We want to definitely have those women prepare by taking prenatal vitamins, making sure they're healthy. Like I said, we have a lot of patients in our practice who are same-sex couples using donor sperm. So, okay, I have another question. Just looking here, hold on here. There is a question about what are the best things to do to prepare for an egg retrieval. And so I think what maybe we should mention are, you can think about preparing as in, how do I prepare and try to get the best eggs I can for my IVF cycle versus how do I prepare for the actual egg retrieval? I'll try to touch on both of those things. One of the things to understand is that the eggs, let's say somebody was going through an IVF retrieval tomorrow. The eggs that she's going to be giving us tomorrow actually started to be created 3 months ago. And so it takes, 2 to 3 months for those eggs to kind of go through the whole process and then be the ones that are going to be taken during an IVF cycle. So you want to remember that in terms of sort of saying, okay, like how am I going to prepare myself and my body for the IVF cycle? I want to make sure I'm taking my prenatal vitamins. I want to make sure that I'm trying to be healthy, eating good foods, getting rest. For our patients who are, struggling with their blood sugars, we want to make sure their hemoglobin A1Cs are okay. We want to make sure people aren't smoking. We want to make sure that we're not drinking significant amounts of alcohol. All that stuff, I think, may help. Sometimes there's different supplements that people think about using. The data on them is sort of so-so, but people talk about CoQ10 and different antioxidants. So those are things that, like, if you're going to do it, maybe you would do it for a couple months before you had your egg retrieval. And then I think during the actual IVF cycle, preparing for the egg retrieval in my mind means taking care of yourself, making sure that you're getting good rest, that you're trying to do your IVF cycle not in the craziest time of your life with your family or with your job. And then just making sure that you have support and everything's kind of in place for the actual egg retrieval. Most patients doing an egg retrieval have anesthesia for the procedure. So it's you don't have to worry about the pain during the procedure. And then most of the time our patients can kind of get back to their normal lives in a day or so. I mean, you still may be sore, but people, you know, can get back to work really the next day and kind of carry on with things. So that's a good thing. I'm just looking at some of our questions here. One of the things there was a question about, maybe I'll just kind of address this in general. There's a question about what to do, like if maybe a patient has done IVF in one location and they're considering transferring their care, or, I mean, what really happens more commonly is people just move, right? Like lives are long, people do IVF in one location and then they move to a different state or a city. And most of the time with embryos, so with fertilized eggs, the protocols for how we freeze and thaw them can be pretty similar across different labs. And so one option is, like, let's say if I had a patient that moved to Columbus and came to me and said, look, I did IVF in Florida, I have my embryos there, like, what do I do? Sometimes the answer is, well, let's have you, ship your embryos. There's communication that happens between the sending lab and the receiving lab about the embryos. And then sometimes people just have their embryos shipped to our office. Also, sometimes what we'll do is help patients get ready. Like they'll work with their doctor they had before, and that doctor will kind of work with us and we'll make sure we get the patient ready. And maybe she flies back to the place she made the embryo and have the embryo transfer. So either way is a reasonable option. We just, we always want to be really, really careful with to making sure that we understand everything about the embryos before we accept them, because we never want to get in a situation where we receive embryos and, don't have the same protocol for how to thaw them. So there is some amount of work that goes into making sure that we accept embryos that we can take good care of. But it's usually not that difficult of a practice to do. Okay. One of the questions that, we don't have a ton of information about, but there was a question that just came up on the board about COVID, and, it's obviously still a concern, and people, still need to think about COVID and still need to think about getting vaccinated and taking care of themselves and everything, because it's still an issue that's out there, especially as we all get together for the holidays again. And in general, we definitely have seen that having a person get COVID in pregnancy, especially towards the end, can be related to some negative obstetric outcomes like preterm delivery. But really in pregnancy, overall, things seem to be okay. And the question was actually like if COVID affects egg quality. And I think that's kind of hard to know. There are so many things that go into egg quality that we don't understand. I haven't seen any data or studies that say, patients had COVID, here's what their eggs look like. Then 6 months later, patients did another cycle without COVID and things looked good or different or whatever. There has been, a little bit of studies looking at sperm. And again, it overall seems to be okay. But I think it's kind of hard to know. So we usually don't necessarily like if someone has COVID during their IVF cycle, often they can't proceed because they can't have anesthesia and all of that stuff. But usually we wouldn't say, oh, you had COVID last month, don't try, don't do your IVF until 6 months later. Like we usually don't say that because we just don't have the data to know that for sure. So usually, I would still encourage people to be very careful and thoughtful about, having vaccines and taking care of themselves and everything, but that's usually not a reason to necessarily postpone an IVF cycle or anything. Okay, one of the questions, this is one of the questions. I'm laughing because sometimes people ask questions and I feel like I talk up a lot about this during the day. So One of the questions that a person had posted was about kind of intervals between pregnancies. And there are some guidelines that say, I mean, some of the guidelines say people should wait a year between when they have a baby and when they get pregnant again. Sometimes it says even up to 2 years. And part of that is there are some studies and some data that say that when women have pregnancies close together, they see some negative outcomes in the babies, such that they may be born earlier, a lower birth weight. And so some of the recommendations do say that women should try to wait between pregnancies. So let's talk about that a little bit more. Also, if somebody's had a C-section, sometimes we want their uterus to heal for at least a year before they get pregnant. So, you know, sometimes when people have had a vaginal delivery, we can kind of, you know, talk more about whether that can be shortened to less than a year, but the C-section often means that you have to wait at least a year. And this is often, you know, when somebody asks me this question in my office, I will usually I'll say, well, what did your OBGYN say? Because sometimes the OBGYN, you know, like, we just always want to make sure that we're not doing things that then the OBGYN doesn't agree with, who's going to then be taking care of the woman when she's pregnant. So, you know, sometimes the OBGYN has said, hey, no, it's fine, go ahead, or hey, you know, like, wait until whatever. And so, so I think whether it's a C-section or a vaginal delivery makes a difference. Sometimes whether you're breastfeeding or not makes a difference. There's, you know, a fair amount of our treatments we can't do for patients if they're breastfeeding, because we can't give them the medications we need to give them while they're breastfeeding. And that's okay. We don't want people to stop breastfeeding if they don't want to. Just need to understand that that might be a reason why we may need to wait. But one of the main concerns, which is what one of the participants wrote about, was that, you know, I just had a baby, I want to have another one because I'm worried about my age, and is that a reason? So, you know, maybe that is something to think about. So if we have a woman who, you know, had a baby at 37 and a half and wants to have another one, and she had a very uncomplicated pregnancy and she had a vaginal delivery and she's not breastfeeding, I mean, maybe that would be a patient who, after, you know, talking with her doctor, we may decide to start at 9 months instead of a year or something like that. So it kind of depends on person to person, but it's definitely worth talking to your regular OBGYN about, and then to your infertility specialist about, okay? And one of the patients had a question about premature ovarian failure, and I wouldn't be a bad idea to talk about that for a second. So sometimes we throw these terms around, and I think it's important to try to distinguish exactly what we're talking about. So premature ovarian failure is it's kind of another way to say premature ovarian insufficiency. Sometimes we call it premature menopause. And so that means that a woman has stopped having periods for at least 1 year before the age of 40. So if you're younger than 40 and you haven't had a period for a year, and people are saying that your FSH is high or AMH is low, and we really think that you have gone through menopause before the age of 40, that is premature ovarian insufficiency. That is different than diminished ovarian reserve or decreased ovarian reserve or low AMH or, you know, decreased ovarian reserve, whatever, which is where, like, someone may have a low AMH, but they're still having periods, sometimes even periods regularly. So people with decreased ovarian reserve can still get pregnant, they can still do IVF, they can still have infertility treatment, they can still do all the things. Their chances may be lower depending on what they're doing. But if they're still cycling and still ovulating and still making estrogen and all those things, they can get pregnant. You know, unfortunately right now, the only options we have for patients with true premature ovarian failure is to use egg donation, which is to use, you know, eggs from another person to fertilize them with sperm and then to carry the pregnancy. Depending on the reason the patient has premature ovarian failure, most people with premature ovarian failure can carry a pregnancy, There are some different reasons why people may have may have premature ovarian failure that they might not be safe for them to carry a pregnancy, but that's very, very rare. Okay. All right, one of the other things I want to just talk about, one of the participants had a question about the process of freezing eggs. So if that's something that anybody's questioning, I just wanted to talk about that. And maybe we'll kind of expand on that a little bit and talk about this idea about embryo banking too. So if a patient comes to us and is interested in freezing eggs, really the only reason why somebody would freeze eggs as opposed to freezing embryos would be if they didn't have a partner. Okay, and so we have a lot of patients who don't have partners. They want to have a child in the future, and so they come to freeze eggs, and that's fine. An egg freezing cycle is kind of just like an IVF cycle that has broken up in two different pieces. It doesn't take a long time to get somebody ready to do egg freezing. I mean, we need to check their ovarian reserve. We need to do an ultrasound to make sure that we can easily get to their ovaries for the egg retrieval. We need to do, some basic blood work, and then they can get ready to do the egg freezing cycle. The egg freezing cycle is basically an IVF cycle because the first part of it is doing ovarian stimulation. So patients who are doing IVF to have a baby right now, or patients who are freezing eggs, they both will have take FSH and other medications to help stimulate the ovaries. They also will do, the 8 to 12 days of ovarian stimulation, taking the medications, having blood work and ultrasound about every 2 or 3 days. And they'll also have an egg retrieval. During the egg retrieval, it's a transvaginal ultrasound with a needle that goes into the ovary. We collect the eggs, and then the eggs are frozen that same day. And we only can freeze mature eggs right now. So we know really by the end of the day how many eggs they have gotten during the egg freezing cycle. Usually what I'll do at that point is then there are some nice calculators online that were made from different research studies over the years that helps patients sort of say, okay, like, how old am I? How many eggs did I freeze? And what are my chances of having a baby from that group of eggs? So usually if I have a patient that's doing egg freezing, I'll get back together with them after the process and say, okay, like, how did the cycle go? Here's how many eggs you have, and here's your chance. How do you feel about that? Do you want to do it again? Are you happy with that? Sometimes patients will say, I'm happy. I'll see you when I need to see you. Sometimes patients, come back and a year later and say, hey, I'm ready to use donor sperm, but I want to save those eggs. Or maybe they'll use the eggs, or maybe they'll do both. So then when you use the eggs, or maybe they come back with a partner, a few years later and say, I met somebody, I want to thaw the eggs and put them with my partner's sperm. Sometimes they use donor sperm. So what will happen at that point is we often will get the woman ready to get pregnant, and we will then thaw the eggs. When you use frozen eggs, you have to do a procedure called ICSI. That is the special fertilization of the egg. So when the egg is frozen and thawed, the sort of outside of the egg, called the zona pellucida, sometimes gets a little bit harder. And so for that, we need to do the fertilization of ICSI, where they put the sperm directly into the egg. So that occurs, the egg gets fertilized, it creates an embryo, and then the embryos can either be tested with PGTA, or they can be put directly into the uterus with a fresh transfer. So it's really just kind of like one IVF cycle broken up into two different pieces. And it's a really great option, I think, for women. I think it helps them, understand sort of what their options are over time. And, truthfully, in a perfect world, people won't use the eggs, right? In a perfect world, they'll freeze them, and then they'll decide they'll meet someone and maybe have a kid that way. And if not, they always have those eggs that they can use in the future. So it ends up being, a reasonable thing to do if it's available to you. Let's see here. I'm just reading. Oh, hold on here. Hold on. Sorry, you guys, I'm reading as, let's see, hold on. Oh, yeah. Okay, there's a couple questions, and I think one of the sort of questions that people are asking is, well, let me address this first. A lot of providers, and this is kind of based on data, a lot of providers, when we're doing infertility treatment, any kind, insemination or IVF, there's this idea about when we think about success rates, often what we're talking about is something called cumulative pregnancy rates. And a cumulative pregnancy rate is this kind of thought that, like, if you had 100 couples just like your patients and they did treatment, like, and they did one round of IUI, maybe 10 people would get pregnant. And if you took the next 90 people and did another round, 10 people would get pregnant. If you took the last, so this is like how many people would be pregnant at the end of the original 100. So what we see with IUI, and even what we see with IVF also, is that after about 3 or so cycles of anything, the pregnancy rates start to go down. And it's not like it's less effective. It's just that whoever's left after 3 or 4 cycles might not be, whatever they have isn't being fixed by either the IUI or the IVF or whatever. So we start to see the success rates go down after 3 of something. So that's actually why, if if any of you have been told by your doctors, you've done 3 IUIs, we need to talk about IVF, that's why. And one of the questions was, how many rounds of IVF do you do before you tell a patient it's time to rethink new treatment? I don't know. I mean, a lot of us, I think, depending on what you're getting with the results, I don't like to do the same thing if it didn't work. Usually we try to do something different each time. So if you find that your provider is like not a, if you really have done 3 IVF cycles and they're exactly the same each time, it'd be worthwhile to talk with the provider about why they aren't changing anything. They may have a great reason, but it also might be reasonable to say, well, we did this thing, it didn't work. Like, is there anything else we can try? And like I said, sometimes they may have a reason, but it's also worth just bringing up to them as well. I want to talk about, there's actually a question on here that I think I don't think we've talked about before in this forum, so it might be worth bringing up. The participant asked a question about Asherman syndrome, and Asherman syndrome is kind of in this category of something called like uterine scarring. Inner cavity syncytiae is another name for it. And so it's basically this idea that people can get scarring in the uterus, and it can often, it's not something that people have just like spontaneously, like you wouldn't just have it unless you've had, the most common reasons why people may have it would be surgery on their uterus. So like if someone had a miscarriage and had a D&C, or if somebody had a baby and then maybe their placenta got stuck and they needed to pull it out, or you do a D&C postpartum. Sometimes if people have had a hysteroscopy, like I've had a patient get uterine scarring after a hysteroscopic myomectomy because of the healing. I think if there's anything else, those are probably the big ones, like D&C, either from a miscarriage or a delivery, uterine scarring. And so it can be really challenging to fix that. You can usually diagnose it. It's usually somewhat easy to diagnose with either an HSG, but sometimes better a saline ultrasound, because you can get a better view kind of all sides when you can do a saline ultrasound. Hysteroscopy would also be a way that you can look, and hysteroscopy is when you put the camera into the uterus and look. That can also be another good way to look at uterine adhesions. Hysteroscopy is often the way that it's treated as well. So you usually can go in with the hysteroscope and then use different techniques to try to break down the scarring. And one of the other questions that this attendee had asked in the setting of uterine scarring is there any reason to think about something called endometritis? So endometritis, which is not endometriosis. So endometriosis is when you get painful periods and the cells in the uterus end up in other parts of the pelvis. That's endometriosis. Endometritis is when you get like a chronic inflammation in the lining of the uterus. And what we think about in our field is something called chronic endometritis. Chronic endometritis is usually what we consider subclinical, meaning like the patient might not be having symptoms of it. Because if you really had like full-blown endometritis, you would be having bleeding and, you know, maybe discharge and fever and pain and all of this stuff. What we see in our world is that people have, I mean, maybe the symptom that they're having is that they're having biochemical pregnancies or they're not getting pregnant. Those can be symptoms of endometritis. And, you know, I have gone looking and found endometritis in people who maybe had like a complicated vaginal delivery where they got an infection and we've treated it. I have seen people who have had like retained tissue after a delivery or a DNC, and then they've had endometritis and then we have to treat it. So if, you know, if there's a patient who, you know, maybe had a DNC, had a complication, had scarring, I do actually think, you know, especially for patients sometimes who like didn't have any problems getting pregnant the first time, then they had a miscarriage, they had a DNC, then they maybe have scarring. I mean, that, and now they can't get pregnant. Like, I think that that would be a reasonable thing to look for as well. It's not too hard to look for in the office. I mean, you do have to undergo something called a endometrial biopsy. It's not great. It kind of hurts, but it only takes, I don't know, 30 seconds or something. So you can get through it. And you know, we have to, usually when I do it, I send for the specific staining. So it's worthwhile to make sure that if you have that done, that the doctor is really like requesting specific testing on the tissue that they collect to make sure that you can get the best evaluation for when you have that done. But I think that it's worth looking for in a lot of cases. So let's see here. One of the things I just want to talk about is the holidays. So if any of you, you know, have had infertility or know people with infertility, it's tough, right? So I know a lot of my patients have trouble with things like baby reveals, baby showers, you know, like family gatherings, that sort of thing, because unless you've had infertility or someone you really know well has infertility, a lot of people don't know what to say. You know, you may be, you know, have gotten married and everyone's always asking you, oh, when are you gonna have a kid? When are you gonna have a kid? When are you gonna have a kid? And they have no idea how hard you've been trying to have a kid. So the holidays can be a really tough time for a couple reasons. One, because you have to see all your family members and sometimes they don't know what's going on, or they do know what's going on and they're asking you about it all the time. Or, you know, there's a lot of things about the holidays that are geared around kids and stuff, so that may be difficult too. So, you know, I think it's really important that you take some time for yourself in the holidays. Maybe that means that you take a month off of treatment so you can, you know, just, you know, unplug and you know, like just relax. And maybe you don't do an IUI or an IVF cycle in December. It's going to be fine. You can pick up in January. It's okay. You know, maybe that means you don't, you know, go to your aunt's house because you know that your second cousin is going to be there with her new twins or something. Like, I don't know, maybe you just don't do that. Or maybe you have your mom tell your second cousin that, you know, you can't go. You know, sometimes getting Christmas cards from people is really hard because everyone, as you know, like sends Christmas cards with their pictures of their kids on it. Maybe you have a friend or your partner, have them open the Christmas cards and only show you the ones that don't have the kids on them if that really bothers you. You know, maybe you make new traditions. Maybe you don't wait till, like, you know, a lot of people, when they're ready to have a family, they kind of envision what the holidays are going to be like with their family. And maybe that's taking longer than you want it to. So start new traditions without those things, you know, start new traditions with your partner where you know, do something without having to think about, you know, having kids. I think in general, though, you just, you know, you want to understand that you got to protect yourself a little bit, take time for yourself. and be okay saying no to things that you don't want to do. And, you know, the people that do know what you're going through, enlist them to help. You know, have your sister tell your dad that it bothers you when he, I don't know, says something, you know what I mean? Just kind of take care of yourselves and understand that it is kind of a hard time, and you're allowed to take a break, and you're allowed to take some time for yourself during that. So, all right. All right, one of the other questions is, okay, so somebody had posted a question about, let's see, kind of about a failed frozen embryo transfer. And I want to kind of touch on this a little bit. So one of the things that's different about IVF compared to natural fertility or compared to insemination is that with IVF, that's the only time that we really know that an embryo or fertilized egg is getting into the uterus and that implantation may not be happening, right? So when someone's doing IUI or insemination, like the sperm goes in, you don't really know if fertilization and all that stuff is happening. So there's something called, this idea about implantation failure, which is we are putting embryos into somebody's uterus and they're not implanting and the pregnancy is not getting going. So implantation failure is really only something that can be diagnosed in the setting of IVF. And there isn't even really like a true diagnosis for it. So sometimes people has to do more with like the age of the person's egg and, if there's any other things going on. So if, the things to think about with a failed frozen embryo transfer is, how many times have they had a failed embryo transfer? Has it only been once? I mean, even with a PGTA tested embryo that appears to be normal, even the chance of getting pregnant with that embryo is only about 65%. So there's still a chance that it just doesn't work for reasons we don't understand. We also want to think about, how did the uterine lining look? How was the uterine preparation protocol? Did it look, did the endometrium look thick enough? Were there any problems with it? Was that embryo tested or not? How old was the patient? A woman who has a frozen embryo transfer at 41 has a lower chance than someone at 31. And so maybe it's not that unexpected that that person didn't conceive. What's the uterus look like? Is there a fibroid in the way? Is there, a concern for chronic endometritis? So we think about all of those things. And then there are some other extra tests that sometimes we do. And again, it's not totally clear at what point people should start doing these tests, but one of the attendees of this talk asked about an ERA. So some of you may know about ERAs. An ERA stands for endometrial receptivity assay. And so what that is this idea, I mean, whether you guys know this or not, for those of you who have gone through IVF or have ever had conversations about progesterone with your doctors, this idea about an implantation window or a receptive window is the idea that, an embryo can't just float into the uterus at any particular point in time and implant, right? There's this whole communication that goes on between the endometrium and the embryo about when implantation can happen. It's actually very cool. There's all kinds of data on it, and there's all this talk between the wall of the uterus and the embryo. But anyways, aside from that, what you need to understand is there's this idea that the endometrium has to be exposed to a certain amount of progesterone for it to be receptive and for an embryo to implant. And we have studies about how many hours of progesterone we think people should be on to have that window be receptive, but I don't know if that's right for everybody all the time. We may think that 95% of people need, 60 hours of progesterone before they have an embryo placed in the uterus, but maybe somebody is different than that. Maybe they need less time with progesterone or more time with progesterone. So the ERA, what that is you go through like a mock cycle. So you take all your medicine and everything like you're doing a frozen cycle. And then instead of the date, so on the specific day, instead of putting the embryo in, you have an endometrial biopsy in the office where they then sample the lining of the uterus, test it, and see if the uterus is receptive in that window. And so that is what that is. And the data about ERAs is, it's kind of controversial. And as much as we all, patients and providers alike, want to make sure that it is like, that we wish that it was like the best way for people to get pregnant. You know, the truth is that it maybe not tell us all the answers we want it to tell. So it is a tool sometimes for some patients, but it probably shouldn't be done at the outset on every single person doing a frozen embryo transfer. There's other tests out there that people look at as well, but it's just important, you know, if you have had, you know, 1 or 2 or 3 embryo transfers where there has not been a pregnancy, that would be worthwhile to talk to your provider about the role of other testing and whether they have any concern about implantation failure. Does anyone have any other questions or anything? Okay. So if you do an ERA and use that information and still get a failed transfer, do you continue to use the information? Okay, so this is the tricky thing about doing an ERA, right? Like if you have embryos that are not genetically tested and you do an ERA, and if you believe that, you know, I mean, there's still other reasons why implantation might not happen aside from, you know, the receptivity of the uterus. So that's the other thing too. Like it's not an absolute reason for why people might not be getting pregnant. This is the other kind of limitation of doing that test. So we still tend to use that information. Like we wouldn't discount that timing, but you know, it's still possible to not get pregnant even despite using the information you have from an ERA. Okay. Somebody asked about advice the night before an FET. What I would do the night before I had an FET would be to, like, I don't know, sit on the couch and watch some television show that I probably wouldn't want to admit to other people that I watch. I don't know, have a cup of hot cocoa, something like that. Just do things that make you happy. And then, like, go to bed early, wake up with a positive attitude, and just head on over and have that embryo transfer. So I just think, you know, even through the whole cycle, you have to have, you know, things in moderation, try to take care of yourselves, understand that you're going through something that's really difficult. Try to not over your schedule yourselves during it. I mean, do everything your doctors are telling you to do and take care of yourself and do all of that stuff. But really, like, it's really hard, and you just need to acknowledge that and just, like, take care of yourselves during it. Somebody wrote, and goes a little bit back to our question about, somebody wrote, you know, do you still have eggs with low AMH of, you know, 0.2? You have eggs until you go, I mean, everyone has eggs until they go through menopause. This idea about egg quality, you know, ovarian reserve is this idea about the quality and the quantity of eggs that somebody may have left. And sometimes the quality is more related to kind of like somebody's age. And quality, I mean, like the potential that any particular egg is genetically normal, and it'll give a genetically normal pregnancy. And then quantity has to do with kind of like the AMH, like how many eggs does somebody have left? So for example, like, you know, we could take one person who's doing IVF at the age of 30, whose AMH is, you know, 0.5. She may have good egg quality, but lower egg quantity, versus somebody who's 40, whose AMH is 5.0. She's going to have high quantity, but lower quality in terms of her chance that the eggs are going to be genetically normal. So yeah, I mean, especially with younger patients who have low ovarian reserve, they definitely still have eggs. People still have eggs, even if they have low ovarian reserve. The most important thing to understand is, you know, a low AMH is important, most important when people are doing IVF, because we use that number to help understand the dosing of medications that they need and how many eggs they may get with IVF, which predicts their success with IVF. So AMH levels, and there was another great study that just showed this too. AMH doesn't really predict chance of natural fertility. It doesn't even really predict chance of getting pregnant with IUI, but it is very important when we think about IVF success. So, and then, so there, just a general question or a kind of a more specific question. Somebody wrote, what guidance can I provide with an egg retrieval resulted in 6 fertilized, but none survived past day 5? This happens sometimes. This is really frustrating when we have patients whose embryos don't grow well in the lab. You know, and there's definitely different theories and ideas about this, and how this is managed really depends on what patients want and kind of different options and how their providers think about things too. You know, if you're a patient who really wants to do pre-implantation genetic testing and you really want to have those embryos tested, then you got to meet with your provider and say, look, like, I didn't have any embryos make it to day 5, and I really want to do genetic testing. What can we do with my protocol to see if we can get better embryo quality? Are there things that could change in, you know, lifestyle, protocol, medications, any of those things that may help sperm quality, that may help with sperm or egg quality? The other option sometimes is, you know, sometimes we'll just do a day 3 embryo transfer. So if the embryos kind of look nice on day 3, maybe we would just transfer the embryos on day 3. Of course, if you're transferring embryos on day 3, you can't do genetic testing of them. So it all kind of depends on, you know, what patients' goals are and sort of if there's any other identifiable thing that happened with the cycle that, you know, could explain why someone had poor embryo quality, you know, after day 5. So, well, you guys, I think it's about time for all of you to get some rest. Go to bed, watch whatever you want to watch on TV with the blanket on yourself. No, but I really want to thank you for all coming out and meeting with me tonight. I do want to encourage you guys. It's November, right? It's just the time to rest before everything. It's been a busy fall. It's cold now. The only thing you can do is just kind of rest. So get some rest and take care of yourselves. And you know, we'll do this again. If you had, you know, if you had a good experience, let us know. So we'll maybe do this again in another few months or something. But take care of yourselves and good luck with all of your treatment. And if there's anything you can do, you know, anything we can help you with, you can just give us a call at Ohio Reproductive Medicine. Thank you so much.